Do that. All right. Now we're good evening, everyone. I'm Dr. Michael Twyman. I'm a cardiologist, born and raised in St. Louis, Missouri, practicing in St. Louis at Apollo Cardiology. I do take care of patients worldwide via telemedicine. If you're interested in working with me, just send me a message in the chat box or a direct message, and we'll get you all hooked up. But tonight we're going to be talking about cholesterol, why it's not the boogeyman. It's not the thing that was put into you by Mother Nature, or whatever you believe, to potentially give you a heart attack. It's something that every cell in your body needs to survive. Without cholesterol, you don't survive. So, do a little bit of a background of what cholesterol is, what your body uses it for, and then from a cardiovascular disease standpoint, why cholesterol is not always the biggest concern, and if you're going to be treated, for cholesterol, what you want to know about that. So first off, cholesterol is a waxy substance. It's kind of like something that will not float in the blood by itself. So it's like oil and vinegar. So cholesterol needs things called particles to actually transport them around the system, which we'll get into in just a minute when I start talking about some of the labs you should get. But every cell in your body needs cholesterol. It's something that your body converts into your sex hormones, your testosterone, your estrogen. It gets converted into bile acids so that you can digest your foods. It's in the outer shells of the cell's membranes, so it's for cell stability. And a great majority of your brain is cholesterol. So without cholesterol, you don't survive. So cholesterol is not all bad. It's mainly when the cholesterol gets inflamed or damaged. That's called oxidized cholesterol, and you can monitor that on a blood marker called oxidized LDL. High oxidized LDL is a problem. That damaged cholesterol, your body's immune system sees it as foreign, sends out the attackers, and starts going to war with it. And then the blood vessels get damaged in the process, and this oxidized cholesterol starts getting stuck under the walls of the artery, and plaque continues to build up. But if you have no inflammation and you have relatively normal cholesterol levels, that's not likely to happen. Yes, cholesterol is always going to be present in plaque in the arteries, but it's not always the number one thing that put it there in the first place. People get the big idea that cholesterol is the be-all end-all of plaque buildup in the arteries, when in fact 50% of people who come into the hospital with heart attacks have normal cholesterol. So if cholesterol was the problem, we put people on cholesterol medicines, there'd be no more heart attacks. But heart disease is still the number one thing that's taking people out. Up to 1,700 people a day aren't making it because of cardiovascular disease is taking them out of this world. So cholesterol, is present in plaque, but it's not the number one thing that puts the plaque in the artery in the first place. One of my previous mentors told me that there might be up to 400 different things that put plaque into the arteries. But back to cholesterol. Your body uses cholesterol, but it uses it in a way that these transporters make it in the liver. That's where most of your cholesterol comes from, is your liver. It's not your diet per se. And if you eat a low cholesterol diet, your liver will just make up the difference. So a low cholesterol diet isn't going to reduce your risk of vascular disease. But cholesterol mostly gets made in your liver, and there's these different particles that either transport it out to the system, deliver the payload, and then comes back and recycles it. So there is no such thing as good cholesterol. There is no such thing as bad cholesterol. There's just cholesterol. So in a traditional lipid cholesterol panel, there's 4 numbers. So there's total cholesterol, there's LDL-C, which stands for concentration, there's HDL-C, and then there's triglycerides. So in a traditional cholesterol panel, I also am only looking at 2 things. I'm looking at your HDL and triglyceride ratio. If you divide those numbers, it should be less than 3 to 1. That's a good marker for insulin sensitivity, meaning you're not likely to be diabetic or pre-diabetic. But for example, if you have triglycerides of 200 and you have an HDL of 40, that's a 5 to 1 ratio, then you're more likely insulin resistant. You're having issues with your glucose regulation. It's possible that you're eating too much processed carbohydrates. You could be inactive. You don't sleep well. You're on hormones, steroids, something that's messing up your glucose regulation, or has an effect. You're not wearing your blue blocking glasses and you're getting too much blue light into your eyes or on your skin. That can affect the way that your body processes blood sugar. So the only thing I really look at, again, is the HDL and triglycerides. That being said, if your total cholesterol is over 300, if your LDL-C is over 190, then it's possible you have familial hyperlipidemia, which is a genetic abnormality. About 1% of the population has this, and it just makes you have higher levels of cholesterol throughout life. There's a couple different reasons why. The most common reason is that the LDL receptor is limited in the number. You can think of an LDL receptor like a catcher's mitt, sits out there and it's looking for cholesterol to pull into the system. If you don't have enough of those catcher's mitts, the cholesterol just keeps flowing through the system and the levels keep building up because it never gets cleared. So those people tend to get vascular disease at an earlier age because there's just so much cholesterol going through the system. It's not necessarily the cholesterol is a problem, but if you're leading a highly inflammatory lifestyle, the damaged cholesterol then gets stuck in the arteries. I have many patients with familial hyperlipidemia. Some had vascular disease and have stents or have had bypass. I also have ones that have had CT coronary calcium scores and the score is still 0. So even though they've had these, quote, high cholesterols for 30, 40 years, they have no demonstrable plaque in their heart arteries. So again, it shows you that if you're doing the right lifestyle stuff, cholesterol is not the boogeyman for you. But back to the traditional panel again, if your total cholesterol is 250, that really tells me nothing about your vascular risk. It's almost a worthless number. Again, 50% of people coming into the hospital with heart attacks have normal cholesterol. So just because you have a high one doesn't necessarily mean you're at high risk. High one in parentheses. And then your LDL-C, that really doesn't tell me a whole lot about the composition of the LDL. When you do an advanced cholesterol profile, which I've been doing for the past 8 years, and there's multiple different vendors that use these type of labs, you need to know what the LDL particle number is. The particle is what transports that LDL around. And you also would like to know the size of the particle. The bigger the particle, the less likely it is to get damaged or oxidized. It's like a big tennis ball. It's not going through a tennis net, which would be your artery. Smaller particles, like little golf balls, they just stick around the system longer. They're more likely to get oxidized, and they're more likely to go through the tennis net, your arteries, and get stuck in the walls. So if you have small LDL, that's a bigger problem than if you have big LDL, and you can see that on an advanced lipid panel. So that's the traditional panel. The advanced panel, it's mainly the LDL particle number, the size, they'll be called LDLP, and it'll have small by it or small dense LDL. Sometimes they'll have something called your LDL size. There's an A or a B. You want to be an A. And then at times I will check it. Just more of a habit that I don't is something called ApoB. ApoB and LDL particle number are very, very similar, about 90% similar. So if your doctors are checking ApoB, that's an excellent advanced test as well. And just generally want your ApoB levels under 80 if you've had a heart attack, stroke, stent, or bypass. Then transition a little bit into people who are on cholesterol lowering agents. I'm not going to necessarily get into people's individual stories tonight and tell them yes, no, take certain meds. But for people who are on cholesterol lowering meds, one of the most common ones are the statin medications. I frequently do get the issues with patients being concerned about the muscle aches or pains with the statins, which is the #1 side effect from them. One thing you can do to figure out if you're going to tolerate the statin, if you've talked to your doctor or if you've talked to me, is there's some labs that can tell you if you're a good candidate to be able to tolerate the statins. One is you want to have optimal vitamin D levels. If you have very low vitamin D levels, well under 30, you're much more likely to have muscle aches and pains. If you have your thyroid underactive, you're hypothyroid, more likely to get the myalgias. If you have an APOE gene, which is a genetic test you do at one time, if you have an APOE gene that is a 4, it comes in 2 flavors. You get 1 gene from your mom, 1 from your dad. It can be a 2, a 3, or a 4, and you get 1 copy of each. Normal is a 3 and a 3. If you have a 3 and a 4, or a 4 and a 4, those people with the 4s tend not to tolerate the high dose statins. They might get by with the lower dose ones or the ones that are more water soluble. So you got to be a little bit more careful with those people that got the APOE genes. Then, who are the best candidates to be really concerned about their cholesterol? It's the people who've already had events for the most part. There's no debate. If you've had a heart attack, stents, bypass, stroke, and you're higher risk and your lipids are abnormal, you should consider being on medications to improve that while you're figuring out why those things are so abnormal. Where it gets a little bit stickier is if you're a 40-something-year-old man, no events, and you have, quote, high cholesterol, should you be on any treatment? You can't answer that question based off just what the cholesterol number is. You actually want to know what's going on in the plumbing system. So in my practice at Apollo Cardiology, we look at the arteries themselves non-invasively. There's typically 2 tests I recommend for that. One of them is called the CT coronary calcium score. It's about a $100 x-ray of your heart arteries. It's looking to see if there's any plaque building up in the walls of the artery. Plaque will typically calcify. The more calcium in the walls of that artery, the higher the plaque. So with the CT coronary calcium score, if your score is 0, there's a small chance that you should consider being on statin therapy unless you have a familial issue. If your score is less than 100, lifestyle is still mostly the recommended way to go. Between 100 and 400, lifestyle, yes, potentially supplements, and then you consider medications based on what your other risk profile is. And if your calcium score is over 400, you should consider a statin unless there's a strong reason not to be on it, or you choose not to be on it and you want to try something different. The other test that I typically recommend is called a carotid intimomedial thickness scan. Short is CIMT. It's an ultrasound of your neck artery. It's looking at the thickness of the wall artery. The thicker the wall of your arteries, the more inflammation there is in the arteries. The more inflammation in the arteries, the more likelihood plaque will build up. Scan takes 5 minutes. It measures your artery thickness and compares it to somebody of your own sex and age and gives you a percentile. But the nice thing it gives you also is your vascular age. So if you're a 45-year-old man and your arteries are 45 or younger, you're good to go. But if your arteries are 65 years old, well, I believe it was Dr. Osler had said this many years ago, and I think he stole from another English physician at one point. A man is as old as his arteries. So if you're 45 on, biologically, but 65 on the inside, you're technically 65 years old. So you'd want to be much more aggressive trying to lower your cardiovascular risk. And one of those things at times is going on lipid-lowering therapies to lower the inflammation of the particles that are getting stuck in the arteries in the first place. So if you have those 2 tests and both of them are low risk, work on your lifestyle. If one of them is higher risk, talk to me, talk to your doctor about what you should do from there. So I think that's all I wanted to kind of hit upon tonight, which is kind of what is cholesterol? Is cholesterol the boogeyman? Is it put into you just to give you a heart attack? The answer is definitely not. If you're going to be on cholesterol medicines, what things you can do to lower your risk of having muscle aches and pains from it, and then who are the best people to actually be on cholesterol-lowering medicines? Typically, the people who've had heart attacks, strokes, stents, bypass surgery. So I hope that clears up a few things for you guys, and I'm opening up to questions here. And so I got both Instagram open and Zoom, so you can either type your questions here, or if you're on Zoom, just raise your hand or unmute yourself, and I'll let you guys ask whatever questions you want.
Mike, I have a question. This is Nancy Carls.
Yes.
I have high cholesterol. I've had it for a while. But my doctor, my blood pressure is really, really low. It's like 108 on the top. So he has not subscribed any medication for me because he tests it from now and then, but he just feels like I'm not really a candidate for that. With that being said, I trust him, but I've never had the test done that you were talking about in your lecture here. So maybe that might give me a little bit more reassurance. I mean, I trust Dr. Griffin, but still.
Sure, and I think that's a reasonable approach. Is that when people are concerned about something, is get a little bit more deep into it and figure out, are you truly low risk? And these tests are fairly inexpensive, and they will tell you if you're low risk, keep doing what you're doing, keep working with your doc, keep doing your lifestyle things. But if for some reason you find that your calcium score is 400, or your CIMT shows your arteries are 20 years older than you want to be, then it might be reasonable to consider being on medication to help lower that risk.
Okay. All right. Yeah, I think I would definitely want to get that test done Sometimes the others, you said calcium, and so I also have a little bit of a battle with osteopenia, not porosis, but I have to watch my calcium intake along with my vitamin D. So yeah, I think these all, it's kind of a circle. So yeah, okay, thank you very much.
You're very welcome, thank you. And just a side note, that is a known risk factor for vascular disease is osteopenia or osteoporosis. So that's, when the bones are thinning out, the calcium is being pulled out of the bones. Well, the calcium ends up somewhere, and if it doesn't find its way back home to the bones or the teeth, sometimes it's getting stuck in the blood vessels. So anybody who has osteopenia or porosis, they should likely consider that CT coronary calcium score if they're over the age of 40, because they'll tell you, where is that calcium going?
Right. That's a very good question. Yes. Okay. All right. All right. We could discuss the test later, but thank you so much. This has been very informative.
You're very welcome.
Thank you.
Thank you. And I have a question here. Do I have to stay on my cholesterol medicine forever, or how can I stop taking it eventually? It's a great question. Again, it comes down to the test, don't guess. If somebody has a low risk CT coronary calcium score, and they want to come off their medication, I think that is a reasonable approach, as long as they're doing all the kind of correct lifestyle things, and then repeating a blood work panel a few weeks or months afterwards and seeing where things are going. Things are stable off the medicine, you stay off the medicine. If things all red lighten up on the advanced panel, then you have the conversation. Do you go back on a prescription medicine, or are you willing to do some different supplement regimen to help control it? But first off, we got to figure out why somebody's on the medication in the first place. Again, it goes back to primary versus secondary prevention. So somebody has that stent in their heart, or they have a bypass, or they've had a stroke. Those people are higher risk to have second events. So unless they can't tolerate or just absolutely decide, I don't want to be on this anymore, they should probably be on one of those cholesterol lowering medicines for the rest of their life. If it's somebody that just put, and this happens infrequently, is that somebody checks your traditional cholesterol panel, says, these numbers look high, why don't you go on a statin? And maybe 20 years ago, that was probably the right answer, but there's much more nuanced data now, but that's not necessarily the right answer for everybody. These things do come with side effects. Some of the side effects of the statins, again, can be increases in muscle aches, pains, exercise intolerance. Some of them raise your blood sugar and put you more prone to being diabetic. So you don't want to give somebody something that's going to put them at more risk than the benefit that they could get being on it. So do I deprescribe? Of course I deprescribe. That's one of my favorite things to do, is get people off medications. But I'm always going to test and not guess. I'm going to look at the health of their arteries first. And if things look healthy, come off the meds and then recheck the blood work a few weeks or months later. Great question. I get that one a lot. All right. So question, I don't know exactly if there's a complete correlation, but the question kind of goes back to the calcium. Is there a correlation between the calcium level from a blood test and the amount of calcium that could be in the arteries? I don't think of a low level, blood level calcium would necessarily be the issue. It'd be more concerning when somebody has a kidney disease, or they have something wrong with their parathyroid gland and they have very high calcium levels. If they have very high calcium levels, then that could be a marker that they're more likely depositing that calcium into their arteries. And welcome to the couple other people that just joined on Instagram. I should, unless I mess up the technical component of this at the end, this should be saved. This should go to IGTV later today, and people can watch the replay. And for people watching on Zoom, I am recording at this time, so as long as everything goes well, I'll try to put this one up on YouTube and also the private Facebook group. What other questions can I answer for the group tonight? This is a great question coming in from Instagram. Being a dental hygienist, if I'm seeing calculus in the mouth, would it be safe to assume it might be in the arteries as well? Very much so. So if you have a lot of plaque in your teeth, there's chances that something's going on in your arteries, and that's a good segue a little bit. Is that oral health is extremely important to vascular health. If your teeth are messed up and you have bleeding gums, you have infected teeth, that inflammation, when your immune system's taking care of it, well, there's all these cytokines and chemicals that your body makes, has to get transported through the vessels. Your blood vessels can get damaged in that process. So there's one blood test that I routinely check in this advanced panel called LPPLA2, or it's also known as the plaque test, PLAC. When that test is high, it's an enzyme or protein that's typically found in plaque that's already into the walls of the artery. When that number is high, it's more likely that plaque is trying to grow, and it's more likely trying to rupture. The plaques rupture, and that's what causes the heart attack. And then, I've heard in some instances up to 50% of the time when that enzyme is high, it's due to somebody having something wrong with their teeth. So if your blood levels are high, make sure you're getting routine checkups with your dental hygienist and dentist. But that's a great thing. If you have a lot of plaque in your teeth, may need to consider being seen by a vascular specialist, such as myself. Another great question, how long can it take to reduce the CIMT score? That depends. If people go on a very aggressive lifestyle change, supplement regimen, medication regimen, light diet, it may only take a couple months. I've not routinely checked it in 6 months. I may in the future for patients who really want to know how fast things can change, but typically the repeatability of the CIMT, you usually wait 1 year before rechecking things on that. I have another question over on the Zoom side. My total cholesterol levels are in the desired range, but my WBC runs low. What is good to increase the white count? I don't get sick easily though. Well, that's the point. And this isn't necessarily my area of expertise, but if your white blood cell count low, it can be a marker that either, yes, you have a current infection. It can be a marker that the bone marrow isn't making enough white blood cells, and so people are more prone to infections. It can be a sign of malignancy in some people, especially if they're associated with unexplained weight loss, fevers. So a low white blood count, needs to be checked out. I'm not necessarily the person who's going to be the specialist that's going to actually figure out what's causing it. It's something that should be repeated, and if it's still low, you may need to see a hematologist at least once for them to kind of look through the story, look through the CBCs and say, okay, this is something that's benign and we're not concerned about it, or we might need some further testing. And sometimes that potentially could require a bone marrow biopsy. And a question, if you see heavy calculus, should I suggest a calcium scan? In the right population, typically, if it's somebody over 40 and they have any other concerns, they're pre-diabetic, high blood pressure, then yeah, they should definitely consider the test. The test is generally about $100, and for the most part, it's covered. It's not necessarily covered by insurance because it's a preventative test, but you don't always necessarily need a prescription from your primary doctor. There's a couple of centers around here, at least in St. Louis, you can get them as standing orders. If you need an order for a calcium score, send me a message. We're happy to kind of order them at times. If your score is 0, go back to your primary doctor. But if your score is greater than 0, we do ask that you come in and see us. So, gonna welcome Lachlan here. He's joining from Australia. So we got a person who came the furthest to join tonight. So I know some of the Zoom people might have seen it in the email I sent out today. I sent a link to the podcast I did with Lachlan last week in Australia. He's a young gentleman who's well read in the biohacking scene. So he knows how to do a lot of this health optimization stuff that I frequently talk about. So we had a deep conversation about blue blocking lenses, how light affects your metabolism, affects your sleep, your circadian rhythm. So all the stuff you guys heard me talk about in the office. I did a really deep dive with him last week. It's a great podcast. I posted the link on my website. I'll put it on my new website soon. If you guys haven't seen it, I relaunched Apollo Cardiology. Basically relaunching it as drtwyman.com. If you type Apollo Cardiology, it's still going to go to the old site, but I'm going to have a repository where all these videos are going to sit, and then also some of these podcasts. So yeah, I did this one with Lachlan the other week. I did another one last week, and then actually I'm pretty excited. I got invited to be on the Biohacking Secrets podcast in a couple of weeks. So that'll be a good chat. So question here. Yes, so my previous group, St. Louis Heart and Vascular in Bridgeton, they do the calcium score test. I actually helped set up the program for them for that, and suggested that they charge $99 to be $1 cheaper than everybody else in St. Louis. They can do it without a prescription. Question: what alternatives to statins do I use? It's case specific, so I can't really throw out there like these are what people should should be taking. So, but typically, if patients can't tolerate statins, don't want to take statins for whatever reason, I'm not going to force people to take something. I will work with them. What I can do from a lifestyle standpoint, and then also a supplement standpoint. But some of the supplements I will consider using are omega-3 fish oils, niacin, vitamin B3, uh, bergamot, and berberine. Those are kind of the probably top 4 supplements I'll typically use for lipids. Now this is a great question. I may have to actually do more of an Instagram story for this one. So, for the people that are on Zoom, I'm running this live on Instagram. Every day on Instagram stories, I basically take different snapshots of what my personal day looks like, what my sunrise that day looks like, where I'm in the world. I don't use a lot of trackers full time. I'll just take spot measurements and then put the thing off because I don't want to be exposed to a lot of electromagnetic frequencies or EMFs. But I do routinely measure my heart rate variability in the morning. And for the past few days, I've been wearing an Oura ring at night in airplane mode, take it off in the morning time, that tracks sleep. I've been doing this 75 hard program for 22 days. It's a little bit intense on some of the physical activity stuff you gotta do. You gotta do 2 exercise regimens a day. Each one's 45 minutes long. One of them must be outside. And so you have the potential to be overtraining with this. So this is not necessarily an exercise regimen you do long term. So I want to know what my baseline was and kind of how much stress I'm putting my body under. So I'm monitoring those things. So every day I'm putting them in Instagram stories and saying, okay, this is what's going on and this is what I would do differently. So if you're not on Instagram, understand, but if you're on Instagram, highly consider following me. It's Dr. Twyman, and you can learn what I do on a day-by-day basis. But the question is, could I do a rundown of what my typical day looks like as far as light, water, magnetism? That's a Jack Cruzian term, essentially. So light, water, magnetism, those are the 3 things that are required for life anywhere in this universe. So if you have 2 of the 3, life doesn't exist. And this is essentially what happened on Mars. They don't have a real source of water. Yes, sunlight hits there, and they do have I believe, a small magnetic field, but there is no, complex life on Mars because of that. So this might be something I might do. Like I said, I might do an Instagram live that goes over the full story of it. So I may just say a little bit more on the light part of it tonight. The water magnetism ones are a little bit challenging to go through, but the light, that's where people should start first, and it's probably 80-90% of the story. So typical day for this would be I typically wake up right before 5 a.m. I wear blue blocking glasses the second I get up. I don't turn on artificial lights in the morning time. You can see my background. I have a red light on right now. So I have different red lights in different rooms, get ready for the morning. Right now with the 75 hard program, I go for a 45-minute kind of fast power walk in the morning during sunrise. Then come home. I generally do not eat until at least 8 o'clock in the morning because I'm right now sticking to a 10-hour or less feeding window, so time-restricted eating. Then when I'm in front of the devices that I'm on tonight, I don't have it turned on right now, but typically in front of the computer, I usually use Iris, which is a software platform that pulls out all the blue light from your computer screens. And then on the iPhone that I'm running Instagram on, I do the triple click red trick. I learned that one from Matt Maruka. He has a YouTube video on that. Just look for triple click red iPhone. There's a setting you can go through, and then when you click it 3 times, your screen pulls out a lot of blue and your screen looks more red. Then in the evening time, sun is set, still will keep wearing these glasses. And typically, I honestly don't typically switch over to the red glasses because I really don't have a problem sleeping. All my kind of sleep metrics are looking good. But if I was, having trouble sleeping or if I'm traveling, typically I'll switch out to the darker lenses that filter more of the blue light and most of the green light. That just really tells the brain it's time to go to sleep. And then sleep in darkness, sleep in like a sleep cave. So that's my typical light diet for the day. All right. And back to the calcium score test. Yeah, sometimes if you call it a calcium test or calcium scan, they don't know exactly what that is. That's kind of the shorthand. But if you call it a CT, coronary calcium scan, or coronary artery calcium scan, then they'll know what that is. Or if you just say, I need the, the $100 x-ray for my heart arteries, they know what that test is. Very good questions tonight. And we're waiting for those other questions to come in. Bento Kelly, I did have a Instagram TV a couple weeks ago that went all through kind of my typical light setup at my home, the different red lights that I use, UVA lights, and my photobiomodulation devices. And another question, good one. Do I use a Magnetico sleep pad? If so, why or why not? So the Magnetico sleep pad, I do not use one. Probably two reasons why not. One is at this time, I don't have any mitochondrial disorders that I'm concerned about that I need to reverse. And two is just the cost of the device. I have some other sleep things I use in my, I have the Chili Pad. I have a, organic latex mattress. I have some different sleep, sleep gear that I just didn't think the Magnetico was needed at this point. But the Magnetico is a mattress. It's not a pad because you got to put on the bottom, you put the mattress on top, but it has, I believe you can get up to a 20 Gauss Magnetico. Essentially what the Magnetico does is that it helps the body know that it's nighttime. During the day, there's low magnetic fields in the environment because of the sun, and then when the sun goes away, the magnetic fields are supposed to go up. But because of all the EMFs in the environment, your cell phones, your Wi-Fi, Bluetooth, all that stuff messes up that signal that the body's trying to interpret. And so that Magnetico can somewhat counteract that and let your body know it's truly nighttime. So if somebody has a significant mitochondrial disorder, and by a mitochondrial disorder, I would assume that I shouldn't assume it would be somebody who has a cardiomyopathy, a weak heart, they have coronary disease, they have an autoimmune condition, they have a cancer, chronic fatigue, fibromyalgia. Those are all likely mitochondrial disorders. If you need your mitochondria to make more energy for you, you need to sleep well, and the Magnetico has a possibility to make that happen. And like I said, the other reason I don't necessarily have it is just the cost. These things are a couple $1,000s. So unless you are really high, hardcore biohacker, or you have an issue that you need to reverse, it's not necessarily worth the investment for most people. It's much more important to work on controlling your light environments first. All right. So I usually try to go at least 30 minutes. We hit the 30-minute mark. I'll stay around for a couple more minutes if any more questions are rolling in, but if not, that's okay. I'll be back here next Monday night. The topic next week, maybe I'll do a little bit more biohacking talk next week, and maybe I'll alternate a biohacking and a cardiology specific one. So if you have a topic that you want me to speak about, drop in the comments below or in the chat box, or send me a message, and we'll try to hit upon it. But again, I'm Dr. Michael Twyman. I'm a heart attack prevention expert. I'm a biohacker, health optimizer. If you're interested in working with me, send me a message. My website is drtwyman.com. All right, everyone. Have a good evening. Take care, and to your health, stay safe.